and participants who have joined from various parts of India and outside India. Welcome to this live webinar on myeloma. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome today's guest speaker, Dr. M.B. Agarwal sir from Mumbai, our chief guest for the day, Dr. Amit Khurana from Surat, all discussants and participants to this virtual symposium on managing relapsed refractory multiple myeloma. Before we commence today's proceeding, I would like to welcome and introduce the host and convener for this continuous medical education series under the aegis of Mumbai Hematology Group, Dr. M.B. Agarwal, sir. Sir is Professor and Head Department of Hematology, Bombay Hospital Institute of Medical Sciences, Mumbai. He is also associated with other esteemed institutes like PD Hinduja Hospital, Leelavati Hospital, Fortis Hospital, and Breach Candy Hospital in Mumbai. He is the president of Mumbai Hematology Group as well. I request sir to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit. Good morning to one and all. Also, good afternoon or good evening to others who have logged in from the rest of the world. Today, I will be speaking to you on management of relapsed refractory multiple myeloma. I apologize for the change in the schedule as our guest speaker, who was to speak on myelodysplastic syndrome, is unwell and had to postpone her talk. Today's webinar is brought to you by Mumbai Hematology Group, supported by Zydus, managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and the team from Zydus, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest today is Dr. Amit Khurana from Surat. All our discussants, who are themselves eminent hematologists or hemato-oncologists or medical oncologists, you participants for sparing your Sunday morning, afternoon, or evening. Our discussants today include Dr. Akanksha Chaudhary Bhopal, Dr. Arihant Jain Chandigarh, Dr. Ashish Dikshit Bengaluru, Dr. Chandrasekhar Bendi, Dr. Deepa Rani from Varanasi, Dr. Deepak Garg Delhi, Dr. Deepak MB Bengaluru, Dr. Fahima Hassan Prayagraj, Dr. Govinda Babu from Bengaluru, Dr. Gurpreet Kaur from Pune, Dr. Ifat Jamal from Patna, Dr. Jayshet Mumbai, Dr. Karan Sood Wardha, Dr. Mahesh Rajashekharia from Bengaluru, Dr. Malikarjun Kalashetty Bengaluru, Dr. Mehak Trehan Delhi, Dr. Mukul Agarwal Delhi, Dr. Narendra Agrawal Delhi, Dr. Neha Kamble Pune. We also have Dr. Nitin Gupta Delhi, Dr. Rajan Yadav Ahmedabad, Dr. Rajkumar Ramaswamy Madurai, Dr. Ramesh B. Madurai, Dr. Rashmi Kushwaha Lucknow, Dr. Reema Miria Ibrahim from Kochi, Dr. Sanjeev Kumar Gupta from Delhi, Dr. Sanjukta Rao Bengaluru, Dr. Satish Kumar Bengaluru, Dr. Sita Raman Bengaluru, Dr. Shailendra Prasad Verma Lucknow, Dr. Shilpa Prabhu Bengaluru, Dr. Shilpi Saxena Panchakula, Dr. Sindhura Lakshmi Karnataka, Dr. Suma TL Bengaluru, Dr. Tejaswini Gudibande Bengaluru, and Dr. Vipul Sheth Delhi. It's my great pleasure to introduce our today's chief guest, none other than Dr. Amit Khurana. I don't think I really need to introduce him. He has been with us for last many years in some or the other role, and all these webinars have been possible because of his untiring efforts and being available to us all the time. Dr. Amit Khurana, just to complete the formalities, is a hematologist, hemato-oncologist, and bone marrow transplant physician at Akanksha Hematology Center, Majura Gate, Surat. He got his training in hematology from NRS Medical College, Kolkata. He pursued fellowship in clinical hematology from Topiwala National Medical College and Nair Charitable Hospital, Mumbai. Subsequently, he pursued fellowship in hematopoietic stem cell transplant from Singapore General Hospital, Singapore. He is visiting consultant hematologist and hemato-oncologist at various hospitals of Surat. He is ex-honorary consultant hematologist at Lions Cancer Detection Center at Surat, and he has a keen interest in bone marrow transplant in various benign and malignant hematological disorders. I request Dr. Amit Khurana to inaugurate today's webinar and give us some words of wisdom.
Thank you so much, sir, for that kind words. First of all, a big thanks to you because whatever I am today is all because of you, and the entire credit goes to you. Whatever the name and the credit you have given to me is just unremarkable, sir, and I don't have any words for it, sir. You have been a wonderful teacher for me, wonderful mentor for me, and a wonderful person, always. A good helping hand for me, always, since last 15 years. I'm a very young person to be a chief guest, sir. But in my 15 years of career, I would like to advise all my budding hematologists on few points. My first point is that if you are a hematologist, what is actually a best hematologist or a true hematologist? And if you define a hematologist, a true hematologist, it all depends upon your basic knowledge of hematology to the advances in the management of hematological conditions. Out of all this, the basic knowledge is very important. If you fail in your basic knowledge, in your diagnosis, you won't be able to treat the condition. No matter how strong you are good in your molecular, how strong you are good in your flow cytometry, but if you don't know the basics of hematology, then the condition may be misdiagnosed and you won't be able to interpret very well. For example, I give you a very simple condition, missing a cystocytes on the peripheral smear. A hematologist cannot ask a pathologist to diagnose or to realize the patient has got cystocytes in the peripheral smear. That is a work of a hematologist. Missing a blast in the peripheral smear. It is very important. You know, the basic funda of hematology. A patient has got a very high LDH of 5,000. You must know what are the causes of very high LDH. It may be very simple definition, just a B12 deficiency. And you can just go on doing a bone marrow biopsy for a very high LDH, thinking why pancytopenia is occurring. So this basics hematology is very, very important. Apart from this, you cannot practice hematology if you don't have the recent advances and the update in the field of hematology. So update is very important. That you can get in with all these webinars. So if you are not updated, you will miss the bus. What is happening in the field of, what is the best treatment available in the field of hematology? Another thing what I would like to say to all my young budding hematologists is the best treatment. For example, you have got RARS, SF3B1 mutation, ring sideroblast, luspatercept is the best treatment according to medalist trial. You know that. But you must know the family background of the patient who is coming to you. Will he be able to afford your luspatercept? What is the best treatment for him? Will he be able to afford your treatment or not? What is your alternate treatment available? So every patient is different for you. You may be treating the Tata Birla Ambani. You may be treating a very small person coming from a very small family or income family, but you must know what is best for it. You may be knowing thousands of things, but what is best for that patient, that is very important. So this is very important in the field of hematology. Every patient is very important for you. Plus, education is very important. Not only your education, but education to the physicians, educations to your colleagues, educations to everybody. So education is very important. You must educate. You must be a very good teacher for becoming a very good hematologist. If you're not a good teacher, you cannot be a good hematologist. Apart from this, you must take part in the research setting. If you are not taking part in research setting, then you may miss the bus. But research is very important in the field of hematology to complete as a complete hematologist. One thing I would also like to suggest to you is a word known as spiritual hematology. And what is spiritual hematology is how you treat your patients with your words. For example, your patient come to you with an APML, and if you say that your patient, you have got a blood cancer, he will run off from you. You must know how to break that news very well, very smoothly and very calmly and very humbly. Patient will be asking you thousands of questions, 20,000 questions, 10,000 questions he will ask, but you have to be very humble, very cool when you're answering the patient. You have to solve all your doubts of your patients, no matter how silly it is. So humbleness, you have to be very calm when you talk to your patients. That is the successful in the terms of a best hematology practice. Very important, last but not least, what we all forget is family time. We must give family time. Apart from the busy schedule, what we have, time to your wife, time to your mother, father, to your kids is very important. If you don't give your family time, you will miss the social life of yours. And that you should not happen with the professional life. So professional life, the social life is very important. Timings are very important. And for that, you just need to organize yourself. As Dr. M.B. Agarwal always say, what is required is organize your schedule. 3:30 when he can get up dot at the midnight, 6 o'clock he can take the round. Why can't we do it? We can get up at 6 o'clock, we can get up at 5 o'clock, we can organize our schedule, and by 8 o'clock we can be free, give a family time. That is what is organization is very important in the hematologist life. So without organization, without the family time, without proper organization, I think you cannot be a complete hematologist. So all these points are very important for being a successful and complete hematologist. This is what I need to say. So thank you so much for giving me this so much honor and to be a chief guest for the day, sir. Thanks a lot to you, sir. And whatever I am today is all because of you, sir. Thanks a lot, sir.
Thank you, Amit, for that wonderful, so practical speech. Many have come on this platform and spoken to our junior colleagues, but the tips that you have given probably will be very impactful and may make a lot of difference in their career. Thank you so much for those golden words. I'll start my talk, and after that, Dr. Amit will again take over to moderate the QA session. Okay, you can see my screen, right?
Yes, sir.
Okay, thank you. So today we are going to discuss about the medical management of relapsed refractory multiple myeloma. March is Multiple Myeloma Awareness Month. And I think any discussion on myeloma is mandatory for a hematologist society during this month. Today's agenda, we are going to talk about some definitions. What is biochemical relapse versus clinical relapse? What is early or aggressive relapse versus late relapse? When you manage these patients, what are the determinants of the management? And we'll split them into three: the disease-related factors, patient-related factors. Dr. Amit just brought out the discussion between Ambani versus a Dharavi patient. Then the treatment-related factors. We'll talk about the management options using the big five and the orphan drugs like venetoclax and selinexor. The role of stem cell transplant for the relapse situation, and some very exciting progress that has happened in last 1 decade and probably will still continue for a couple of decades is the cell mode agents, the bispecifics, and the CAR-T. We'll spare some time to discuss three unusual types of relapses: extramedullary, plasma cell leukemia, and the CNS relapse. We'll also talk about how to handle these patients when kidney is not in the optimum situation. No malignancy can be treated without the best support and palliative care, and we'll talk about that. And the optimism that all of us have. Can we conquer and cure myeloma? And lastly, the unfinished agenda in 2025. So too many things on the plate. Let us see how much we can discuss. The good news today is in 1990 to 2000, we talked about that we can make a patient of myeloma live for 2 to 3 years. During last 5 years, we have been talking that patients can live for 12 years plus. This is a huge achievement in 20, 30 years. Essentially, myeloma is non-curable. We got to accept that bitter pill. There is a non-malignant accumulation, which is asymptomatic, and we talk about MGUS and smoldering myeloma there. And then the myeloma appears on the scene. It becomes symptomatic. You treat it, achieve remission, it relapses. You treat it, it relapses. And one day it becomes refractory to everything that you have in your armamentarium. Not only that, the irony of the situation is that with each relapse, the response duration shortens. So when the patient relapses for the first time, you can still achieve a remission for a significant duration in years. But when the second, third, fourth, and fifth line of treatment is offered, the remission lasts for shorter and shorter and shorter period, and later on just probably for a few weeks. So let's define the biochemical versus clinical relapse. Biochemical relapse is when the increase in the serum or urinary monoclonal protein is more than 25%, or the serum free light chain ratio goes up by more than 25%, or there is an increase in the clonal plasma cell population by more than 10%, or there is an increase in the size of the plasmacytoma or a bone lesion on the MRI by more than 1 centimeter. Any one of them is enough to label the person as asymptomatic biochemical relapse. What will be your action? If all these 4 criteria are not met, then you just increase the frequency of your follow-up. This patient whom you were calling once in 3 or once in 6 months, you'll probably now call them in once in 2 months or maybe once in a month. If any one of these criteria is met, then you need to treat this patient as relapse, although this will be a non-aggressive relapse. The question that a student may ask is, when a patient is asymptomatic and there is no organ dysfunction, nothing has happened to kidney or bone, nothing has happened to the marrow function, why should you treat a biochemical relapse? And the reason is that these patients may quickly get onto the damage to kidney before you realize, or may damage their bones before you realize, or can develop a plasmacytoma compressing the spinal cord or some other vital part of your body. On the other side, the clinical relapse. Clinical relapse is very easy to understand. This is undergraduate stuff. You probably fulfill either the CRAB criteria on the left side, that is hypercalcemia, renal failure, anemia, or lytic bone disease, or the SLIM criteria, where the bone marrow plasmacytosis is over 60%, or the involved light chain to uninvolved light chain ratio is more than 100, or there is more than 1 focal lesion on the MRI scan. Either CRAB or SLIM, the action will be treat this patient as an active disease immediately. Let us now define 2 more terms. Early, which is often aggressive, versus late relapse. So early and or aggressive relapse. If your patient is on treatment for myeloma and progresses, then that is one of the most aggressive disease you can ever think of. Those patients who relapse within a year of autologous stem cell transplant are also aggressive. Rapid onset of SLIM or CRAB, ISS 3 straight away at the relapse, that is either high LDH or high beta-2 microglobulin or low albumin. Fish studies that you must always do at relapse showing you high risk cytogenetics. Or there is a relapse which is extramedullary, or there are circulating plasma cells at relapse, or there's an isotope transformation, that is light chain escape or hyposecretory. These are all either called early or aggressive relapses, and they need very aggressive management. There is a huge difference in the final outcome of early relapses versus all other relapses. As you see over here, the 50% overall survival for late relapses can be in decades, and that for early relapses is just about 3 to 4 years. Coming to the determinants of the management. So this is a very sweet, nice cartoon that I I've taken multiple undergraduate classes for. So you have disease-related factors, your patient-related factors, and your treatment-related factors. Disease-related, you look at, is there crack? Is there extramedullary disease? What is the stage of the relapse? What is the cytogenetics? Patient-related factor, you look at the frailty, you look at the comorbidities, you look at the social support and the living environment, which Dr. Amit just described about. And then the treatment-related factors, are you going to give support care? Is your treatment goal to achieve MRD negativity or just improve the quality of life? What will be the route of administration of the drugs, oral, parenteral, drips? And what will be the adverse effect profile of whatever you're offering? Now let's go into the depth of first the disease-related factors, which are most important because this will help you in risk assessment. Standard risk assessment, which is done in clinics, is by looking at the clinical features together with simple blood tests like albumin, beta-2 microglobulin, LDH, and you look for or search for extramedullary disease and plasma cell leukemia. As was mentioned earlier, look at the genomics, especially the fish. And then you also look at the clinical course. Whatever treatment you offer, what has been the response to the treatment? Are you achieving the MRD negativity, or is the patient again going to relapse very quickly? All this put together give you a comprehensive risk assessment. Something which is not routinely done in India or probably not in clinics, even in the Western world, but very soon will be at your table desk is the next generation sequencing, the whole genome sequencing, gene expression profiling, immunophenotyping to look at the circulating plasma cells, cytoph, and the peripheral blood MRD, that is circulating tumor DNA, and the mass spectrometry. Some of these are realities in major or minor exclusive myeloma centers in Europe and US, but none of them are probably done routinely or even at the research tool in India. I don't have to spend time on this myeloma risk defining factors because they are similar to a newly diagnosed patients. Suffice to say that a standard risk patient has either hyperdiploidy or 11-14 translocation, and these patients have a longer survival. On the other extreme is an ultra high risk disease, which is extramedullary disease, or there is a biallelic TP53 inactivation, high risk GEP, circulating plasma cells, early relapses in less than 12 months, primary refractory disease, or the FISH criteria, which we all know very well, including deletion 17p. And rest is all in between. Once again, as I mentioned about the early and the late relapses, those patients who have relapse with high-risk cytogenetics versus standard risk cytogenetics have a huge difference in their survival. Detailing the patient-related factors, I will like to pay attention to the fitness and frailty. A patient might have relapsed after 5 years, and during these 5 years, he might have developed certain complications which make him totally unfit and frail. Once again, without going into too many details, we all are aware of the looking at the comorbidities. There are challenges in diagnosing symptomatic myeloma. There are problems with tolerability of the therapeutics that is there in your disposal. There may be a very brittle performance status. There's limited evidence-based treatment for very elderly people because these people do not form a part of the research protocols. And there could be patients who are at higher risk of infection, higher risk of VTE, higher risk of neuropathy, and higher risk of treatment failure. So elderly people or very elderly people have very specific problems which you must pay attention to. And you can't treat a 40-year-old relapsed myeloma same way as an 80-year-old relapsed myeloma. Also, it's important to understand that at relapse, patient may be fit, but after a couple of cycles, he may become vulnerable and can become frail. On the other side, your patient at relapse diagnosis may be frail, but after treatment, he may become vulnerable and then fit. On day one, you thought that you can't give him most of the treatment, and maybe after 3 or 4 cycles, now you feel that he's fit enough because his morbidity was due to the disease, and hence he was frail. The treatment-related factors are probably what you're waiting for. So what's our armamentarium when the patient relapses? It's not very different from when the patient is newly diagnosed. But yes, there are certain tools which you do not use upfront in 2025, but they are there for you, approved by FDA, approved by DCGI for relapsed patients. So quickly going over, you got proteasome inhibitor, immunomodulators, alkylating agents, targeted therapies, traditional immunotherapy, advanced immunotherapy, and the salvage transplant. Immunomodulatory, you got lenalidomide, pomalidomide, thalidomide. Proteasome inhibitor, you got bortezomib, carfilzomib, ixazomib. Steroids, you got dexamethasone, prednisolone. Monoclonal antibody, you got daratumumab, elotuzumab, and isatuximab. Antibody drug conjugate, you got only one, that is belantamab. XPO inhibitor, you got only one, that is seloxanone. CAR-T therapies, you got 2 approved ones, ida-cel and cilta-cel. And conventional chemotherapy, which can never be forgotten. You got DSAP, you got VDT-PACE, you got bendamustine, you got cyclophosphamide, and you got melphalan. So a student of myeloma has to search the best option for the first and the last relapse of his patient between these 15 to 20 tools. Few things which I have learned over last 1 decade, and which I will like to share because I still do not see this commonly practiced. The use of our pharmaceutical agents have to be little smart. Bortezomib must be used only once a week and only by subcutaneous route. 1-4-8-11 twice a week protocol is obsolete. It produces a lot of neuropathy, and it is not superior in its efficacy to once a week. The moment there is a patient who comes with raised creatinine, there is a temptation. I see a lot of young myeloma doctors using 1-4-8-11 protocol, not required. Also, there is a problem that number of bortezomib available in the market, the package insert only mentions about IV because they've only gone to the drug controller for IV approval. The same product can be used subcutaneously without any change in the pharmacopoeia. And you have to remember that you don't learn your pharmacology by the package insert, but from science. You must not use bortezomib intravenously in any patient, however advanced the disease may be, because it is not superior to subcutaneous and produces tremendous amount of peripheral neuropathy. Sometimes there is a little wasted interest that intravenous therapy will be always done in your nursing home or in your hospital, and patient will be staying there for certain hours. Now we have to bypass that kind of thinking and please use it subcutaneously. Carfilzomib, when it came, it was for 2 consecutive days, day 1, 2, 7, 8, and so on. Once a week is as good as 2 consecutive days. Thalidomide, when it came, it was 400 mg, 800 mg, even 200 mg is toxic. 100 mg per day is as good and much less toxic. Lenalidomide, well, everybody is aware and everybody practices this when the creatinine clearance is low, and often we look only at the creatinine. We do not look at eGFR or creatinine clearance, but it's very important to avoid the marrow toxicity of full dose lenalidomide by looking at the creatinine clearance. Pomalidomide came as 4 mg per day. 2 mg per day is equally efficacious, much less toxic, and there's no place for using 4 mg of pomalidomide. Daratumumab, Faspro, that is subcutaneous, has come. There is no place now for intravenous Dara infusions, which has a lot of infusional reaction and occasional death can occur due to anaphylaxis. Also remember that pre-medication for subcutaneous Dara are required only for the first cycle. These are not required from second cycle onwards. Dexamethasone. Well, steroid is as old as melphalan in the treatment of multiple myeloma. I often wonder, in a country like ours, where almost everybody in the age group where you get myeloma is pre-diabetic, do we really benefit from using dexamethasone? Should dexamethasone be continued for that duration for which we do this? Should it be used in combination with other such wonderful potent drug? You don't use it now with bispecifics. Do we need to use it with daratumumab or lenalidomide or proteasome inhibitor based? I'm not sure. But anyway, what I have written over here is what the pundits mentioned and what the research has shown, that 20 mg per week is more than enough, at least during the follow-up of the patient after he has achieved VGPR. You do not need 40 or 80 mg per week. And even this 20 probably will be brought down very soon. Selinexor, we don't use it. 100 mg is not required, 50 mg is enough. And now the two bumper drugs, teclistamab. It has knocked your doors. Now all of us are using teclistamab-based therapy for our relapsed myeloma patients. We have to learn this very hard way. Someday we will talk full lecture on this. What I would like to mention are two things, which I have learned in last 3 months. One, once you achieve PR, partial remission, once in 2-week dosing is enough. You don't need to give it every week. And second, although the package insert and the publication mentions that this is an indefinite treatment, our patients do not have money and they do not require the indefinite schedule. All of us have now seen that the patient gets into very stringent, complete remission with MRD negativity very quickly, within about a month or two. Majority of these patients can stop their treatment or can have holiday, and you can restart the treatment as and when required. And telcotamab will be available to you and me in November, December. The dosing of this, once again, can be just once in a month once you achieve the partial remission. This is going to make teclistamab and telcotamab both very user-friendly, very financial friendly, and possible for probably 10 times more patients than what we are doing today. So, multiple roads to go. Which one will you like to choose? You've understood the disease-related factors, the patient-related factors, and your armamentarium. Obviously, you don't tell patients or you don't tell your junior colleagues that 1, 2, 3, 4, 5, 6, 7, choose what you want. You are the boss. You have to show the way. You have to tell them one protocol that the patient has to start with. You may modify it as and when required due to lack of efficacy or toxicity. But it has to be just one protocol from your pen on the paper. For example, you write carfilzomib because you used your brain, you used your knowledge, used all your intelligence to decide that this patient needs a PI and that PI has to be carfilzomib. The background thinking of this doesn't have to be loud. You don't have to speak it out to the patient because he does not understand ABC of why you have chosen carfilzomib. I come to the 5 big. What is this big 5? The terminology comes from Africa. These are the big 5 of African wild sanctuary. And our big 5 are bortezomib, carfilzomib, lenalidomide, pomalidomide, and daratumumab. When your patient relapses, go through all his prescriptions from day 1 till he is relapsed and see whether any one of these drug has not been used for him. Then that's your automatic choice. Second, whether any one of these drug was used long ago. So patient is not refractory to that drug. For example, patient may be on maintenance therapy with lenalidomide, but patient might have used bortezomib 3 years ago. In that case, borte can be used again, len cannot be used again. So your combination will be carfilzomib, lenalidomide, and so on. What are the protocols which the patient might have used upfront? It may be VRD, VTD, CyBorD, rarely KRD. If the triplet, which is the most popular regimen in India, has been used. If it is Western world, then it is usually quadruplet. Maybe patient has received Dara VRD, Dara VTD, Dara CyberD, or Dara K. So you should first look at all his prescriptions that he received triplet or 4 drugs and which was the combination that he has used in past. You got to make up your mind whether the patient is double refractory patient. That means he's refractory to a PI and IMID. He's a triple refractory patient. That means he's refractory to a PI, IMID, and DARA. And he's a penta-refractory patient. That means he's refractory to 2 PI, 2 IMIDs, and DARA. You got to have this clear information before you choose your protocol. Well, in cancer, you're all oncologists or budding oncologists. You have been taught, and we practice this, that your best treatment, your best foot has to be put up front. So today we don't use a weak protocol to a newly diagnosed myeloma patient. We use the best protocol. And you look at these graphs, the overall response rate, VGPR, CR, and the MRD negativity. And you see some of these protocols have got the highest result when they are used upfront. So these are protocols using DARA, carfilzomib, lenalidomide, dexamethasone. So protocols like MASTER, Griffin, and so on. So when you do the combination like this upfront, you do achieve deep possible response, MRD negativity, very long-lasting responses. But that does leave you with very few options when the patient comes back to you with relapses. Now, if I show you that upfront data, the upfront data of a DARA-based protocol gives you MRD negativity of 75% versus 47% with a triplet, then won't you be tempted to use DARA upfront for all your patients, provided the money permits? You will be. And why not? You should do it, because that gives you the best of the hope, longest hope. Somebody who's 50 years, maybe at the age of 62, he is still in MRD negativity. And that's what you and me have been doing today. If your patient is a very high risk or ultra high risk myeloma to begin with, then there are protocols like this from UK called MUK 9B protocol, where you use 5 drugs induction, where besides Bote, Len, Dara, and Dex, there is alkylating agent. And then during transplant, you use Bote plus high dose melphalan. Then you give consolidation 1 with 4 drugs, consolidation 2 with 3 drugs, and then you give maintenance with 2 drugs using Len and Dara. Now, when you got such kind of protocols used for ultra high risk myeloma, your patient probably behaves as if he's standard risk myeloma to begin with. But when he relapses, your many options are lost. I'm not saying that you should not use this protocol upfront, but you have to take all this into consideration in planning the next line of your treatment when the patient relapses. So what do I do? So if patient has been exposed to Len, I use POM, Thal, then I use Len. If the patient has been exposed to Bote, but long ago, then I use Bote again. And if he was on Bote at the time of relapse, then carfilzomib. Ixazomib is only if the patient can afford and desires an oral PI. Dexamethasone, prednisolone, in relapse setting, I use only dexamethasone. DARA, I'm not allergic to DARA because like rituximab, you use even for all relapse protocol for lymphoma, I use DARA for all relapse patients, even if it has been used upfront, because there's data to show the addition of DARA, and I'm going to show you that data today. Alkylating agents, if you have used high-dose melphalan, then autologous transplant upfront, then it is cyclophosphamide now. And if you are forced to use, then you've got these orphan drugs like venetoclax and selinexor. There is no place for monotherapy when the patient relapses, but I will have to bite my word if I'm discussing bispecifics. Except for that, the drugs have to be in combination. The quadruplet is better than triplet, and triplet is better than doublet, cannot be denied even in the relapse setting. The minimum has to be triplet. And this is a nice saying, 3 times the giggles, 3 times the chaos, and 0 time to sit down. Now look at the protocols that are available at your disposal, from where you have to make up your mind when the patient is sitting in front of you, and in 10 minutes, you've got to write down what you're going to use. What this slide shows you, 1, the types and types of triplets that are available to you, and 2, that all these triplets are better than combination of two drugs or the doublets. So you got DVD, you got DRD, superior to VD and superior to RD. You got DPD, superior to PD. You got DKD, superior to KD. You got KRD, superior to RD. You got ELO-RD, superior to RD. You got ELO-PD, superior to PD. I'm not going into the details of this protocol. It serves no purpose. Protocols are there in the books. Protocols are there on the net. But what it shows you is that the age-old, very well practiced, very well sort of advertised Castor and Pollux studies have all shown you that triplets are superior to doublets in a relapse setting. And you've got options, which with the background that we just spoke, you can choose one then the other. The work goes on. You've got ISA-PD versus PD, ISA-KD versus KD, PVD, VD, you've got SVD, VD, etc., etc. So you've got almost about 10 protocols in your hand, and all triplets are superior to the doublets. Few words about monoclonals, and we have only one at our disposal, the DARA. I like to quote the Pollux study because a lot of us will use DARA RD or RD when our patient relapses. So this is the Pollux trial. And what it showed was that DARA RD is superior to RD for progression-free survival. DARA RD is superior to RD for overall survival. Whichever way, whether you use RD or DARA RD, if you achieve MRD negativity, then your overall survival or progression-free survival is superior to patients who remain MRD positive. Coming to the Castor, because that's the other protocol which you may use. Your patient is on LEN maintenance. He's relapsed. You will use DVD versus VD. And once again, if you look at the MRD negativity, that gives you the longest progression-free survival, achieving MRD negativity. And if it is with triplet, it is better than doublet and so on. This chart is under the glass on my table. This is a master chart. You don't have to listen to Dr. Agarwal or any other scholar from anywhere in the world. You can choose your protocol based on this, even if the patient is sitting in front of you. You must look at it because otherwise you'll make mistake. What this chart gives you is various protocols that I just showed you on the top. And you see there are almost more than 10 of them. And on the left side, it gives you in the bottom the patient's comorbidities. Does he have a cardiovascular risk factor? Does he have neuropathy? Does he have cytopenia? Is he very frail or aged? Does he have kidney impairment? And then it gives you an analysis of previous protocols to which he has been exposed. And your analysis is that he's LEN resistant, DARA resistant, BOTE resistant, DARA plus LEN resistant, DARA, LEN and BOTE resistant, POM resistant, KV resistant, etc., etc., or penta-refractory. So once you know the previous treatment and your assessment says that he's resistant to 1, 2, or 3 of these drugs, and you know all about the patient's criteria, patient's related factors, then you just look at the ticks and you pick up the protocol where there is a tick, and don't pick up a protocol which are empty boxes. Okay, so without wasting much time, this chart has to be on your table. And this is something which you have to remember in your background, that there are 50 more studies available in the literature for relapsed patient. What is the hazard ratio? If you are using a protocol like CyBOR-D for a relapsed patient, your hazard ratio is the worst. While you're using a DARA Lendex or DARA Carfildex or Carfildex, Carfilzomib Lendex, your hazard ratio is the best. So I'm not discussing at the moment any financial issue. I'm going with the science. So your top half gives you the best of the chance of achieving the best, deep and long-lasting results than what is there at the bottom. I love quadruple. The quadruple which may be used in the relapse setting is DARA KPD. Hardly any one of us will use Carfilzomib upfront, pomalidomide upfront, and dexamethasone and DARA. You sort of give it to everybody because there is no talk about developing resistance to these drugs. So many of the patients of mine who relapse receive these 4 drug combinations. And the results are over here for you to see. MRD negativity, overall response, and 98% 1-year progression-free survival. Let's talk about the orphan drugs, the venetoclax and selinexor. When will I use venetoclax? Venetoclax remains an orphan drug in the armamentarium of multiple myeloma. It's an oral, so that's wonderful. It's a BCL2 inhibitor, we know that. It has made inroads and it has changed the life of patients with CLL and AML. And you and me are very happy today with AbbVie having licensed this drug officially in this country. And today we can treat our patients with venetoclax for newly diagnosed CLL, for relapsed CLL, for newly diagnosed AML, for relapsed AML. So venetoclax is wonderful there. Now, what about myeloma? For myeloma, this is not a wonder drug. First of all, in myeloma, we don't use targeted agents, isn't it? Whatever may be your fish data, you use what has been spoken so far. And the reason for that is we don't have targeted agents. This is the first targeted agent. So we were very excited 10 years ago. And with that, T1114 translocation occurs in myeloma in 15 to 20% of patients. So excitement has to be there. Venetoclax results into, this translocation results into cyclin D1 upregulation. This is most commonly seen in patients with plasma cell leukemia, 40% of patients, and the brother of myeloma, light chain amyloidosis in 50% of patients. Even then, you do not see venetoclax being used in a newly diagnosed amyloidosis or in a newly diagnosed case of plasma cell leukemia. And the reason for that is, one, of course, the research does not exist. Two, the approvals do not exist. Three, even in the relapse setting, the results were not extraordinarily. I agree that upfront the results may be better, but the drug has been notoriously known to produce a lot of infections. Alone, it does not work. It has to be given in combination with some PI, like bortezomib or carfilzomib, plus minus steroids. And there is a real, genuine enhanced risk of infection. So it's there for relapsed patients who have got 1114 translocation at some stage, but not in every patient of relapsed who has got 1114 translocation. And you should look for the 1114 translocation, because before you tell the patient that all my tools are exhausted, this tool is still there with you, which can give a lease of 1 year, 1.5 years to the patient's life. Selinexor came and it has sort of disappeared because simultaneously came the bispecifics and CAR-T. Selinexor is selective inhibitor of nuclear export. It is EXPO1 inhibitor, always used in combination. The tremendous advantage is it is like venetoclax, an oral drug. The huge disadvantage is even 50 milligram is difficult to tolerate by the gut. And when the gut is not good, how can you continue a medicine? It's impossible. In practice of medicine, GI tract has to be very comfortable with the molecule. Will you do transplant for a patient who has relapsed? Yes, there are indications. First, we'll talk about autologous. More than 90% patients in India do not get upfront ASCT. Some of these may be because they were not fit. So obviously they will be worst when they've relapsed. They'll be more and more unfit. But there are many patients who didn't get it because of maybe financial constraint, which they may not have at the time of relapse for some reason, because of some mental block in the patient's mind or relative's mind, and that block might disappear when the patient has relapsed, and so on. So if you have not received ASCT upfront, think of it. Then those patients who have relapsed after ASCT, after 2 or more years of progression-free survival, that means the high-dose melphalan had beautifully worked. It gave 2 years of freedom from relapse. Obviously, this kind of situation requires that you have collected stem cells for 2 transplants and you have the facility for cryofreezing. There is a bad word in the treatment of myeloma, and that bad word is allogenic transplant. The moment you use this word, you start looking at the other side. Yes, allogeneic transplant in myeloma is not popular. The Western world does not do this, and it more so does not do it because now they have easy access for BiTEs and CAR-T. I'm going to discuss BiTEs and CAR-T, but what percentage of our patients can spend, even with Indian CAR-T, 40 to 50 lakhs of rupees? I'm not saying that allogenic transplant is cheaper, but is half the cost. The problem with allogenic transplant is non-relapsed TRM, which is over 40%. And you don't want to kill 4 out of 10 patients straight away. Still, I would say in India and the rest of the developing world, if you've got a patient who has got a high or ultra high risk disease, who's got unfavorable karyotype, who's young, who is fit, and has had multiple relapses, all your tools are exhausted, and he's still, say, about 40-year-old. He's still very fit from the angle of organ function profile. His disease is something which is going to kill him in next 2, 3, 4 months. Then it is worth taking a chance with allogenic transplant. If he's got money, if he's got a donor, maybe somewhere somebody will be cured. And we do it. Work in progress. So we come to now things which are not very easy, but we have to know because these are drugs of today and these are drugs for tomorrow. The cell mode agents, the BiTEs and the BiTEs against BCMA, BiTEs against GPRC5D and FCRH5. Against BCMA, we already have it. All of us have used it. GPRC5D is going to be there with us in November. The ADC targeting BCMA, I don't think we are going to use it. And the CAR-T, and I'm going to touch upon the CAR-T, which is going to be available to us in 40 lakhs by November. Against BCMA, of course, not against the others at the moment. So cell mode agent, the one which we have not touched, of course, we talked about thalidomide, we talked about lenalidomide, we talked about pomalidomide. But the drug which is knocking our doors, which has been approved in the Western world, and therefore we need to know this, expensive, but one day, somewhere, some patient can afford it, is iberdomide. It is far superior to all the existing cell mode agents. And if it becomes available to us, we will talk about it. Coming back to the immunotherapy. Now we are going to talk about bispecifics. What a change it has made in the future of relapsed refractory myeloma patient. So plasma cells has a lot of targets on its surface, and each one of them has been researched. I'm not going to talk about all these targets, but you have to know everything, full length, about CD38, daratumumab, BCMA, we're going to discuss at length just now, GPRC5D, by November it is in your hands, and the FCRH5, and one day maybe CD19. Let's talk about what we already have in our armamentarium in India. For last 6 months, we have teclistamab. And let's look at the Majestic 1 study. The results are something which you could have never imagined. They are astonishing. 2 out of 3 patients respond, and 40% of patients achieve complete remission. And the median time to achieve the initial response is just 1 month, and the median time to have the best response is 4 months. And the duration of response is 1.5 years. Give me one example of a monotherapy when used in relapse setting, works so fast, gives the best results in 4 months, and the duration of response is 18 months. And this is median. Half the patients will have longer response. The progression-free survival is almost about a year. There can't be a better example than a bispecific giving you results in the relapse setting. And therefore, teclistamab is the drug of choice for your patients who are penta-refractory. 65.1% overall response rate across the dose level in patients of relapsed myeloma has been shown both in the research tool and both in the real world. And now we have got 3 bispecific antibodies. Teclistamab, we just showed you the data. Talquetamab, which will be with us by November. And Pfizer is trying to bring the elnatamab. So 2026, 3 bispecifics. You should read this editorial, the embarrassment of riches. You will be now searching in your mind, which one should I use first? It's not bispecific versus CAR-T. It will be one bispecific or the second one or the third one. Which one to start with? And then comes the CAR-T. CAR-T for ALL, approved. CAR-T for lymphoma, B-cell lymphoma, approved. CAR-T for myeloma, getting approved in November. If you are a student, what is CAR-T? CAR-T-C is your own T-cell. The virus is inserted into this T-cell to create a receptor on its surface, which is a chimeric antigen receptor against an antigen on the plasma cell. So that is CAR, chimeric antigen receptor. And then this CAR-T, when given back to you, latches onto the cancer cell and kills the cancer cell. If I go a little bit on detail, so you collect the blood, separate out the T lymphocytes, do the genetic engineering on it, create the CAR receptor on its surface, grow the same with culture, give chemotherapy to the gentleman to deplete him, and then give infusion of this autologous T lymphocytes. So it's an autologous transplant with a gene therapy, combination of two beautiful technologies, as a result of which you have such handsome results. Now, comparing CAR-T with bispecific, for that has been a question in everybody's mind, where both the modalities are available, and you will have this available by November to you. Efficacy-wise, the red is the CAR-T, and the blue is the bispecific. So CAR-T is pooled CR, CAR-T is superior to bispecific. Pooled 1 year progression-free survival, CAR-T is superior to bispecific. Look at the adverse effects profile, and this is 10 studies on 700 patients for CAR-T, 6 studies on 600 patients bispecific. Now the toxicity profile, the CRS is more with CAR-T than bispecific. Neurotoxicity, ICANS are more with CAR-T than bispecific, and infections are more with CAR-T than bispecifics. Number of us have already burnt our fingers by using bispecifics in India and the infections. So, you need to give it to 5-10 patients to really master how to prevent infection, how to treat infection, give prophylactic antimicrobials, give intravenous gamma globulin every month, and so on. Similarly, we have learned how to avoid cytokine release syndrome by giving prophylactic tocilizumab so that you can use bispecifics on OPD basis. Bispecifics are available to you across the corner. So you can just pick it up today and use it today. And as I mentioned, you can do it in an OPD procedure, and you can prevent infections by the methods that we have. So I think bispecifics, we have become very user-friendly today. CAR-T, the negative part of CAR-T is wonderful. I mean, I cannot discuss the advantages of CAR-T in this talk, but remember, CAR-T is not very effective for extramedullary disease, and the present CAR-T is not effective in high-risk cytogenetics. Our CAR-T at the moment is against BCMA, and it is autologous. It is possible that tomorrow, when the CAR-T will be against GPRC5 or bidirectional or allo CAR-T or against NK cells, maybe we will be having a better tool. CAR-T and bispecifics today are used as the last resort. But day is not very far when you'll be using it in the earlier line of treatment. It's possible that tomorrow, if your patient has got an early and aggressive relapse, by choice, you will offer them bispecific or CAR-T. If your patient has had an extramedullary disease or high-risk cytogenetics at relapse, you will offer them these upfront. So it is possible that even the big 5 have not been used, and you may use them, but that's not today. Why am I saying that CAR-T will be in your hands by November is this. This is our indigenous CAR-T, the DRL 1801 from India. Origin Oncology Limited recently announced the promising results of phase 1 study from the India's first trial for the novel autologous BCMA-directed CAR-T therapy for patients with relapsed refractory multiple myeloma. And that's the center in Bangalore. At the bottom, the Origin phase 1-2 open label multi-center study called SWASTH to evaluate the efficacy and safety of DRL 1801 in relapsed refractory patients. The data was presented in Brazil in the 21st annual meeting of International Myeloma Society, where we showcased the India's contribution to the global cancer research in the form of indigenous CAR-T, the cost of which to your patient may be just under 40 lakhs. And this is the data that was presented. And the fascinating results of our indigenous CAR-T. Number of patients, 8. Overall response rate, 100%. Complete response rate, 7 out of 8, 87.5%. Partial response, 1 out of 8. MRD negativity, 6 out of 8, 75%. And look at the side effect profile. Grade 3 CRS, 0. Grade 3 neurotoxicity, ICANS, 0. Neutropenia, thrombocytopenia, anemia are expected, and they're occurring 62%, 25%, 25% of patients. So our indigenous CAR-T showed 100% clinical response in heavily pretreated myeloma patient, with 62% achieving stringent complete response MRD negativity without any high-grade CRS or neurotoxicity. So that's a great news. We don't have to send our patients for CAR-T abroad. The million-dollar question is, should my patient go for bispecific? Should my patient go for the CAR-T? If yes, then which bispecific? And if yes, then which CAR-T? And a day is not very far where you will probably be using multiple immunotherapeutic tools together. Well, can't you use teclistamab with daratumumab? Probably yes. Talking about EMD, PCL, and CNS disease. I know I've exceeded my time, but I'm going to do this because this is important. Extramedullary disease, at initial diagnosis, often is in the skin. And you see 5 patients over here. At the relapse, also, it could be in the skin. On the left side, patient has relapsed. On the right side, this is post-treatment. At relapse, it can happen anywhere. This is a testicular extramedullary relapse. This is a cardiac extramedullary relapse. Extramedullary relapse is an extremely aggressive form of myeloma. It occurs from a clone, which is now growing independent of the marrow environment. Myeloma remains inside the marrow because it is dependent on the environment for its survival. But now this cell does not require the marrow environment for its growth. So it can happen anywhere. A true EMD is a soft tissue plasmacytoma, not next to the bone or not connected to the bone. It occurs in the skin at initial presentation. At relapse, it can happen anywhere: liver, kidney, lymph node, breast, CNS, body cavity. In a newly diagnosed patient, the incidence of EMD is 0.5 to 5%. In relapse setting, it is to the tune of 5 to 15%. And the prognosis as of today is dismal. All of you will like to know what we do for the extramedullary disease. The routine protocols do not work. Use anti-lymphoma protocol. Always trust alkylating agents like VDT paste-based therapy. Daratumumab has some place, transplants have some place, CAR-T may work, future CAR-T. Extramedullary disease, if it is at 1 or 2 places, radiotherapy is a wonderful tool. And if it is surgically excisable, even that is a tool. So though survival is short, but these give a lot of relief to the patient. And this is the way to handle EMD. And this is an article published 3 years ago by John Blade and his group. Plasma cell leukemia is another very rare and aggressive disease. It also invariably has very unfavorable molecular abnormalities. By definition, there should be 5% or more circulating plasma cell, but any patient who has circulating plasma cells has a dismal outcome. It could be primary or secondary. Despite aggressive management, survival is short. What should you do? If available, you should go for BiTEs or CAR-T or allotransplant. The rest of the treatment, median survival is just 6 months. CNS disease is another horrible disease. It could be parenchymal or meningeal. Untreated Survival is 2 months, with treatment 8 months, with transplant 18 months. What are our tools? High-dose dexamethasone, systemic therapy, triple intrathecal, cranial radiation, drugs that can cross blood-brain barrier like IMIDs, and probably the other novel agents. Many of them are actually ineffective. Relapsed myeloma with impaired kidney function. Can't go into too many details, but there can be various types of problems. Amyloidosis, glomerulonephritis, light chain deposition disease, cast nephropathy, which is commonest, and the tubulointerstitial disease. Kidney biopsy will tell you what has happened. How do you manage? Usual reversible factor like dehydration, hypercalcemia to be taken care of. I want to emphasize, high cutoff dialysis is useless. Don't spend your money. With present drugs that you have at your armamentarium, plasmapheresis is not required. Now this, our young colleagues have to learn. I see everybody rushing for plasmapheresis for patients who have relapsed with renal impairment. I will tell you the reason for that. Aggressive management of myeloma does the same thing as plasmapheresis without the agony of plasmapheresis. Using DARA in this situation is extremely helpful. Don't count the cost of DARA. Just count DARA to get the kidney back to normal. Alkylating agents are useful, like cyclophosphamide, and the IMID that is used commonly is thalidomide. You can use pomalidomide as well. Don't use lenalidomide. Bisphosphonates, contrast dyes, nephrotoxic drug. And autologous transplant is not contraindicated in myeloma kidney disease. Now, this is published yesterday. Blood Advances, 2025, March 14. Early use of DARA, study of 20 patients, small number, but very useful study. The reduction in serum free light chain assay occurred by more than 50% within one cycle of DARA. The median time to reduce the free light chain by more than 50% was, look at this, 3 days. Your plasmapheresis cannot also do this. So 88% of patients achieved serum free light chain assay reduction to below 500 after one cycle. And the median time to this was just 2 weeks. So DARA becomes mandatory for patients who have relapsed with kidney. I would say the same applies to newly diagnosed also, but we'll discuss the relapsed patient. So key takeaway from this publication, which has just appeared, is early use of DARA-based combination in myeloma. Admitted with kidney injury, rapidly reduce the serum-free light chain. Early use of DARA combination improves renal function and avoids, nullifies plasmapheresis. I can't discuss support and palliative therapy, which has to go hand in hand with whatever we have spoken. Take care of anemia, take care of bone disease, etc., etc. Last 2 things. Can myeloma be cured? And what is the unfinished agenda? So who is our enemy? Our enemy is the plasma cell. And our enemy is that one day all patients become relapsed and refractory to our existing too. Lisa Ray, diagnosed to have myeloma in 2009. In 2012, she declared herself to be cured and got married to Jason Denny. Same year, she relapsed. However, there can be no match to Lisa Ray's spirit. In 2018, after 6 years of relapse, she became proud mother of the twin daughters. And these twin daughters today, Sufi and Solel, are 7 years old. Today, Lisa Ray hasn't seen myeloma again. She's NRI, lives in London. She was invited to the Pravasi Bharatiya Divas 2025, and she became an integral part of the event. She's one example who relapsed when he thought she is cured, went on to get married, have kids, and after the treatment of relapse, has not got a relapse for years, almost going to touch a decade. Her myeloma began 16 years ago. Can I use the word she's cured? Maybe. Many celebrities and big names were not so lucky. They succumbed to myeloma despite all the tools in their hand, all the money at their disposal, and the best of the center in the world treating them. There are others who are very spirited, who are still fighting because they have disease in remission. They're not cured, but they are on maintenance therapy. So we are waiting for the cure to happen. Many of these patients are very, very old, and we aspire to cure the disease. And there are these dedicated workers in the world, both US, Europe, and maybe even in this country, who spent their life like the gentleman at the top, Robert Kyle, for last 50 years. And the others, many of them are very young. And they have been doing research to get rid of this disease and cure it. Reframing myeloma from fatal to a chronic disease has happened, and now probably potentially curable. The road to the cure is very convoluted, and there are various ways to achieve this. You've got to choose at least one way. We are becoming successful, but this success is like an inchworm. We are inching towards the success. Many a little makes a miracle. How do we cure myeloma? Two things that we have already discussed. Use the best risk-adapted treatment, quadruplet, early transplant, consolidation, maintenance. Use the best tool for the relapsed patient, bispecific, CAR-T, and others. There is no doubt that at least today, the road to cure is allotransplant, bispecific, and CAR-T. We use the word today, functional cure, normal relative survival, and the true cure. True cure is like Lisa Ray. No evidence of disease in the body 16 years after having the disease in yourself. And all of us have such patients. 10% of myeloma patients are truly cured. Not because you and me worked hard on them, because they had a disease which was genetically a less serious disease, a less low-risk disease. Functional cure is cure where MRD can be detected, but they never get over relapse. And there are patients there. A normal relative survival is a patient who's got disease for decades, and then he dies of a heart attack. So he died of his age, but not of myeloma. I may not have time to go over this chart, but this is a beautiful chart to make you understand that there are patients who cannot be cured, and you know them in day one. There are patients who have operational or functional cure, and there are patients probably who are genuinely cured. And the Lisa Ray example is on this side. These are patients who achieved MRD negativity by the best possible tool. They're fit patient. They were standard risk patient. They were early stage patients. They were treated very early. They received the best of the treatment. They received the best lines of treatment, even in the relapse setting. They achieved MRD negativity by the best possible tool, and so on. So at the moment, functional and long-term survival are our goals. And my second part of the roadmap to cure myeloma is, yesterday what we thought was experimental, today is reality. Achieve MRD, not only MRD, achieve sustained MRD. And the definition of sustained MRD today is more than 1 year. Look at the MRD by next generation flow, next generation sequencing, spectrometry, and the PET defined. And lastly, nip in the bud. And I'm going to spend 2 minutes on this to understand the epidemiology of the disease, the genetic evolution of the disease, and a philosophical talk. Should we act at the level of MGUS? Should we act at the level of low-risk smoldering myeloma? So a lot of our patients come over here with the overt disease and we treat them. And we go right up to operational cure, undetectable MRD, and probably those 10% of patients who are really cured. As I just talked about the MRD detection, there are tools and tools. but the next generation flow and the next generation sequencing, the PET scan, which is a functional imaging, are important. And we should have a tool like mass spectrometry at our disposal to know the real, genuine MRD negativity. And this is mass spectrometry-based assessment of M protein in the peripheral blood during the maintenance therapy published last year. Modern myeloma treatment and sustained MRD negativity is equal to functional cure is this editorial. So we have ticked most of the boxes, and the last 1 minute. Nipping in the bud. All other cancers, we do this. The moment cancer is detected, we act immediately so that the cure rates are the highest. Why didn't we do this for myeloma? Because we didn't have the tools, but here we have the tools. And to understand those tools, to act at the bud level, we need to understand the evolution of the disease. All patients with extramedullary disease had overt myeloma one day, smoldering myeloma prior to that, MGUS before that, and a normal plasma cell earlier. What converts this normal plasma cell to MGUS? If you learn this, you can act here and prevent myeloma from happening. And probably today, we should think of acting at the level of MGUS and early stage smoldering so that you never have overt myeloma. Definition of MGUS, smoldering myeloma, biochemical myeloma, and the CRAB is all well known to all of us. But this is what the attention of researchers is today, that from a normal B cell, the MGUS and the overt myeloma and the extramedullary myeloma is an evolution at the genetic level. And when we are diagnosing these patients here, a lot of things have happened. It's not like BCR able of CML, where you're just having one enemy. Now you've got hundreds of enemies. So acting here is much easier than acting here. So what we were observing yesterday, what we are controlling today, will be probably curing tomorrow. So we have opportunity of preventing myeloma from happening by preventing MGUS from happening. We have an opportunity of early intervention at the level of MGUS and early smoldering myeloma. And we have the opportunity of curing by doing MRD testing to know whether we have achieved what we want to achieve and we can maintain what we have achieved. This is the epidemiology. You all have heard of I-STOP-MM. I for Iceland, S for screens, O treats and prevents multiple myeloma. I-STOP multiple myeloma. Two things that came out of this project. This is the largest single country, Iceland-based study, which has ever been conducted in the field of cancer. Hats off to the guys. And what this study has shown, MGUS affects 5% of population over the age of 40. Before this study, we didn't know this. 85% of these patients are undiagnosed. In India, 99% of these patients are undiagnosed. After 40, 5% of population has MGUS. And the same study shows you the smoldering myeloma after 40 affects 0.5% of the individuals. And as the age advances, the number keeps increasing, and the males more than females. The Black Swan Research Project, BSRP, early aggressive treatment, if you offer to high-risk myeloma patient, as is active myeloma patient, there is a dent. The Aquila trial is daratumumab monotherapy at the level of high-risk smoldering myeloma, and the results are 63% progression-free survival at 5 years versus 40% when the myeloma became active. So acting early works. Now this has to move if we have proper tool to early smoldering myeloma and maybe tomorrow MGUS. So the summary and the conclusion of my talk is the cure of myeloma is in the sight. And we have to think of all this, and probably 40 people have to work together looking at the precursor disease, the environmental factor, the population screening, like the data that I showed you, sophisticated testing like MRD, the genetics of myeloma, the early aggressive treatment, etc., and of course, on the top, the global collaboration. Lastly, the unfinished agenda. Should we diagnose patients at MGUS and intervene there? We don't know. to recognize the heterogeneity of the myeloma and individualize the treatment. We don't do this. In the era of bispecific and CAR-T, should we still continue maintenance therapy until progression or intolerance? We don't know. Utilizing MRD for guiding the treatment and de-escalating the treatment. We are not doing this. Incorporating immunotherapy like bispecific CAR-T upfront. Based on the disease biology, we are not doing this. Is there a role for chemotherapy in relapsed patients, or it should be all immuno? What is the optimum timing of using bispecific and CAR-T? We don't know. What is the sequencing of various immunotherapies? The 3 bispecific, more on the pipeline, 2 CAR-Ts, and more in the pipeline. And should then the autologous transplant be abandoned? We don't know. Success is not the ultimate goal. Success is a journey, and we are moving towards this. This lady, she knew that she had cancer and she's out of it. Well, defeat myeloma, hum honge kamyab. Thank you very much for paying attention to what I spoke for longer than what I was supposed to.
Thank you, sir, for that wonderful lecture. I think this was the best lecture we have ever heard from you, sir. Great lecture, and it was a heart-touching lecture. No words for it, and I think, sir, hats off to you. Now I request all our discussants to please put the raise hand signs so that we can start our question session with Dr. M.B. Agarwal, sir. Yes, Dr. Sanjeev Gupta, your question, please.
Yeah, thank you so much, sir, for this wonderful talk. And I must confess that listening to your talks is not just an academic experience, but it's a spiritual experience for all of us. And you make the topic understandable by everyone, including hematopathologists. So from our perspective, I would like to ask you about your practice regarding the use of flow cytometry in myeloma at MRD level time points, as well as at the time of diagnosis. Like, do you use flow for suspected cases of myeloma to look for clonal plasma cells, or you just rely on the biochemical evidence of clonal protein?
Right. So one, we don't do it for everybody at diagnosis, because at the moment, immediate treatment does not warrant it. Two, those patients who can have access to all the possible tools at relapse, we like to do the MRD assessment today. This may apply to 1% to 2% of my patients. Most of the patients will not have access to the benefit that I will offer them after that MRD assessment. So it remains a neglected tool, I should say. We have an access to this in Mumbai, but remains a neglected tool.
Thank you so much, sir.
Thank you, Dr. Sanjeev Gupta. Dr. Mehat Rehan.
Am I audible, sir?
Yes, you're audible.
Good afternoon, sir. It is always a pleasure to hear you. And thank you, Amit, sir, for the practical advice and the words of wisdom you gave at the start of today's webinar. Sir, I have a question to ask. So you talked about biochemical relapse in the beginning of the webinar. So, sir, should all biochemical relapse be treated, or there are some patient subsets, let's say slow rising M-band or standard risk patient, where we can delay therapy? And how do we choose the first line treatment post biochemical relapse?
So the biochemical relapse now has a definition laid down by the working group. I showed you the 4 criteria: more than 25%, more than 25%, more than 1 centimeter, and all that. So once you fulfill any one of them, then it is a very high risk disease for developing overt myeloma. And because you can't do PET scan every now and then, patient may not even come to you for looking at the kidney every now and then. You may miss the bus, and patient may straight come to you with a raised creatinine or a lytic area somewhere in the bone with bony pain, a vertebral collapse, or even an extramedullary disease. That is the reason why this definition has been laid down, that once you fulfill one of these criteria, the overt relapse is imminent. So you may act. It is just like treating high-risk smoldering myeloma or treating SLIM, because none of those patients have overt disease. None of them are having any symptoms, but we are treating them today. So it's from the same token. So biochemical relapse, if it fulfills the criteria, treat them. If it does not fulfill the criteria, but you have noticed that there is a progression of the disease at biochemical level, decrease your intervals for calling the patient for follow-up. Our patients of MGUS and smoldering myeloma, early myeloma are called once in 3 months. Some of them don't even come once in 6 months. But once you have this data that the things are progressing, then you have to be more careful. You should, like Amit said in the morning, you should spend some time and explain them why they need to come more often. What was the second part of your question? How do you treat them? I think that was the whole talk. So you
Thank you.
select your agents, patient-based factor, disease-based factor, tools available to you.
Thank you. Thank you, sir.
Thank you.
Dr. Mehak. Dr. S.P. Verma.
Thank you, sir. Very nice talk. It was mesmerizing. Just wanted to know, like, do you do MRD, flow MRD assessment in all your patients in routine clinical practice, and at what time points if you do it?
Questions is almost identical because asked by Sanjeev. We do MRD assessment in patients who have got everything available at their disposal. Good education background, good financial background, ready to go on the drop of the hat to MD Anderson or Sloan. Now, those are the patients where we do everything. Because if we don't know, you will be an inferior doctor to them. There are patients who have done their MRD abroad and now they want you to do the MRD here. They're not even happy that you're doing only flow. They keep asking for even NGS. So, Mumbai practice is quite different. So you've got all these guys who have been moving around the world. But as I said, this applies to 1% or less than 1% of patients. For majority, I don't do it because it achieves nothing. Because we can't implement the information.
Thank you, sir.
Thank you. Dr. Aryant.
Good afternoon, sir. So thank you for the talk. One question: in young fit patient in the current era and who is affordable as well, would you omit an auto transplant in CR1 in any given situation for a newly diagnosed multiple myeloma, or would you offer auto transplant to all?
Very simple answer, auto to all. The bispecifics and CAR-T in future may make the auto redundant. For once again, majority of the patients, including, I would say, affluent class, where money is not an issue, as you mentioned. This is one-time treatment with negligible mortality, with minimal morbidity. You use a very powerful tool like high-dose melphalan. The only thing that comes in my mind is the data that when you use high-dose alkylating agent, that could be the genesis of second cancer. And there is data that those who are on len maintenance, who had not undergone auto versus who had gone under auto, those who had undergone auto, the risk of second cancer was highest. So it's possible tomorrow with the bias. When I say this, where do we know the cancer genesis or oncogenesis of CAR-T? Or where do we know the oncogenesis of immune paralysis by bispecific? This have been just a story of less than 5-10 years. It's possible that a 40-year-old young guy who get CAR-T dies of tomorrow a T-cell lymphoma or other cancers. So all these are dangerous tools. You are playing with nature. But yeah, as I said briefly, today, all patients ASCT unless there's a reason not to do it.
And one more question. Have you already adopted the Aquila approach of treating smoldering myeloma with DARA?
Me, no.
Thank you.
Too expensive for me. For majority of the patients, there are question marks. So that is a study, and I keep it as a study. Before you stop asking question, I must say that Arihant has impressed me in last 5 years. Whenever he has asked questions in all the meetings where I have been present. And the same word I would say about Mehak Trehan. Youngster, Mehak Trehan, not so youngster, Arihant, are champions in field of hematology.
Thank you,
Thank
sir.
you, sir. You have made our day.
I have not exaggerated ever.
Thank you.
Thank you, Dr. Aryan. Dr. Ramesh?
I must add Ramesh to that list.
Thank you, sir. Thank you so much. Kind words from you. It's a great talk from you, sir, as usual. So I have three questions, sir. So first question is, I've used teclistamab in one of my patient who had a refractory myeloma. Just one dose was given. He did not have very severe CRS. He just had a grade 1 CRS. But following a week of teclistamab, unfortunately, he had sepsis, landed up in septic shock, and he expired. What is you might have used in teclistamab in many patients? Like your opinion on teclistamab, sir?
So according to Jensen, I have the highest number of patients on teclistamab today. Yes, Ramesh, I'm very scared. Infections have been a nightmare. And on teclistamab, it is very disheartening. You make a patient spend so much money, and then your patient got sepsis and died. I have patients who have had repeated admissions for infection. I mean, sometimes I'm embarrassed to face them when they ask, is this treatment related? Because last 10 years I had myeloma, I had never had this.
Mm.
I have to say that, yes, this is due to teclistamab. Therefore, I have come to a conclusion we have to use teclistamab very carefully. There is no way to go away from it. You and me have to use it. Penta-refractory, the situation that you mentioned, for a patient who can afford teclistamab, why not? It's the best tool you have at our disposal. We must use all the agents to rule out infections before we use this. Simple thing like urine, routine, X-ray, chest, all markers for the infections. We must use very liberally the antimicrobial prophylaxis, which you will be doing, I will be doing. We must vaccinate them as much as possible, whatever tools we have. I'm now convinced that all of them must undergo IgG. And even if the IgG is borderline normal, 400, 500, we must give them monthly intravenous gamma globulin. If we don't want the second patient to die of sepsis, they must receive intravenous gamma globulin. It is almost mandatory. Meera Mohan, she's going to be our speaker within a month. I've heard her multiple times. I have read her extensively. She's a masterpiece in infection prevention on teclistamab and other bispecifics and CAR-T. Her publication, and recently I think Indian myeloma working group, doctor from PGI and others put together their head and have published an article as well. How to prevent infection and treat infection on bispecifics and CAR-T. In this country, this is an issue. Again, the educated elite and the moneyed people also, when it comes to fever, they take it very lightly.
Mm.
The GP handles them, the patient reaches you only when they are in shock. So,
Yes, sir.
irony of the situation that our patients do not have problem of CRS and ICANS. They do not have problem of HLH. They're getting problem of infection. I have already started using this drug in half the dose, once in 2 weeks. And the moment they get stringent CR, I'm giving them holiday. I don't follow what Jensen says. I'm not doing it for the cost factor. I'm doing it for preventing death by infection or morbidity by infection. Another element which you may face is severe fatigue. I don't know whether you face this in your patient or not. Patients are mentioning that they just can't go to the house. They're so tired right in the day, morning when they get up. They don't feel like getting up from the bed. They get up at 10 o'clock. They don't go out to the house. They don't feel like working, sitting in a chair. This is not talked about in the literature, but I'm facing this with a patient. A lady said she used to spend her Saturday, Sunday in the club. She doesn't feel like going to the club, which was recreation for her. But she doesn't feel like, because she doesn't feel she's got enthusiasm left or the strength left. And she's on no other drug except teclistamab. So I'm not against teclistamab at all, but we are learning how to use teclistamab. Whole world is probably learning how to use teclistamab. I have had similar experience with CAR-T. Those patients who went abroad and did their CAR-T, Auntie done, patient has come back. Now you have the music. Cytopenia, blood transfusion, platelet transfusion, no neutrophils, very low neutrophil, IgG low. You are now dealing with 10 diseases. So these are wonderful methodologies, but we are not expert in that. We are learning these things. Take time.
Yes, sir. So my second question is, in which set of patients do you use carfilzomib upfront, sir?
Okay, so these are ultra high risk and to some extent high risk patient or patients where bortezomib could not be tolerated or was contraindicated due to diabetic or alcoholic neuropathy. So patients who had bad neuropathy, patients who got bad diarrhea with bortezomib, they refused to take it further, or bad fatigue. So all these patients where I couldn't use bortezomib, or they had I believe that this is a superior drug to borte for high risk and ultra high risk. I had a debate with Bhausaheb Bagal on this, carfilzomib upfront for ultra high risk and high risk, and I firmly believe the reason behind this not using may be that you lost one drug. Will you use Borte after failure of carfilzomib? We don't have data, so we don't do that. Will you use POM in front and then use LEN? We don't have data. So we probably lost out of the 5 big sub-tools when you use these upfront. So everybody will not do this. This is not standard of care, but there is a place for carfilzomib upfront.
Okay, sir. So do you do sequencing at baseline, sir, for all like TP53 mutation sometimes can miss, like 17p deletion can be picked up in the fish, whereas like we'll miss the TP53 mutation if it is present if we don't do sequencing. Do we need to do if a patient is affordable, or can we skip it if we do fish?
So I don't do this. I stop at deletion 17p by fish upfront and at the time of relapse. I've not been looking at TP53. I do that for CLL. I've not been doing for myeloma. If one day I have some data that, yes, this is helpful, maybe I'll do it.
Okay, sir. So my last question is your opinion on the dose of melphalan in autologous transplant, 140 milligram per meter square versus 200 mg per meter square.
I'm myself not a transplanter, but I understand 140 is a compromise. They use renal. Amit, you can answer this question better.
So, sir, if the patient is fit, I'm using 200 milligram meter square only. But for renal compromised patients, 140 is fair enough. Even I've got low to 100 milligram per meter square also in some patients. So
okay.
Standard of care, 140 is a compromise.
140 is compromise, yes.
So in some patients, like I've noticed, like they do not develop mucositis also, like not even mucositis of grade 2. So I doubt like whether the drug is working at sometimes with melphalan. If I give it 140 mg per meter square, like that's why I'm little. I'm in a dilemma. Like that's why.
My patients of lymphoma, when they get CHOP and they don't lose hair, they come and ask me, the brand that you described was correct or wrong? So there are patients whose hair are so resistant to chemo. Everything happens, but the hair remain what they are. So maybe your patients, the oral mucosa is so good that they don't get mucositis. Amit, you want to answer that? Some patients don't get mucositis.
So
Something to do with the brand, or that's what my question is, sir.
It's something to do with the pharmacokinetics and the pharmacodynamics of for every patient actually. So even I've seen the 140 milligram patient has got a very bad mucositis, bad diarrhea lasting for 14 days, 15 days, diarrhea is not going. And even sometimes there is also late mucositis also. But recently I did a transplant and the dose was kept 200 milligram meter square. The dose came out to be 360 milligram. Patient did just only 1 or 2 days of diarrhea. That's all. No mucositis, no oral mucositis, and patient was discharged in the 7th or 8th day. So I think it's just about pharmacokinetics. Some patients do badly, some patients do very good, some patients can tolerate nicely. I think that's the whole thing about it.
Okay, sir. Thank you. Thank you, Mitsu. Thank you, MB also.
I shouldn't say much about the brands, but I must say that 10 to 20 Indian pharmaceutical companies, their brands are on par with anything in the world. I can never forget an example of, we have a global hospital here, the trustee had myeloma. He used to import Revlimid. And then he heard the cost of lenalidomide in India. He was shocked. He said, this cost, it must be fake. Then he sent a capsule to Boston. They analyzed it. He said, this is on par. And he started saving the money and said, I'll give this money to the myeloma poor patients now. So our drugs are on par, at least for the top 10, 20 pharmaceutical companies.
Good to hear that, sir. Thank you.
Thank you, Dr. Ramesh. Dr. Neha Kamble.
Before Neha asks question, I must add her to this list. She's another wonderful hematopathologist. My first encounter with her was about 2 years ago when she called me to Pune for a talk in one of her meetings. And I must say, what a dedicated, knowledgeable, and enthusiastic researcher she is in the field of hematopathology. Ever since then, she has been my speaker in all the meetings that I've done. So wonderful, great future.
Good afternoon, everyone. And I'm very grateful and thankful for the kind words. And I believe I've been always saying this to MD Agarwal sir, beginners like us always need mentors like him. So I believe I have learned much more after I've started attending the conference, much more I've started being as a speaker with so much of inputs from so many discussions. So I believe my learning phase has actually started after I met you. It started better after I met you. And it's always a pleasure to have you with us, sir. I have a small question regarding multiple myeloma. So this is in continuation of the lecture that I had in the last conference in January. So I covered over plasma cell neoplasms, and we were talking about MRDs. So there is a lot of tumor heterogeneity that we talk about in multiple myelomas as well. So a single, group of tumor cells, a few cells have a different molecular signature, a few other have a different molecular signature in close vicinity to each other. So when we are talking about the primary diagnostics and the MRD at the same time, uh, just as we have precision medicine or precision oncology, I believe is there time to have precision MRD analysis also, which should change from patient to patient because the tumor heterogeneity changes from patient to patient.
So I've learned from your statement. I cannot answer it. I've learned something. Yes. Sure, I agree. And full stop. Can't answer or can't anything to you.
So my question was from a clinician's perspective. So what kind of the different response to therapies that you're seeing as per the protocols in different kinds of patients? So does tumor heterogeneity have a role in it, or is it the constitutional makeup of genetic makeup of a patient, or the maybe epidemiological changes or geographical changes that contribute to differences in treatment responses amongst individuals?
So as a clinician, we believe that every cancer, whatever name you may give it, that name is very artificial. So when you say myeloma, and you say all this is myeloma, there are probably hundreds of subtypes, and those 100 subtypes are genetically determined. Yesterday, we had a talk on childhood ALL, and Dr. Tichy from Boston beautifully described how the standard risk acute lymphoblastic leukemia with 95% cure rate has got hundreds genotype, which we were not aware of because they were all getting cured, so they were all lumped together. So based on the basic science and those studies, probably myeloma is an extremely, extremely heterogeneous disease. It's not even that simple as acute leukemia or CML. How to study those tools, how to differentiate them, whether that will ever reach to a clinician, not in my life, but even in youngsters' lives, I have no idea. But yes, you guys have to dissect that out so that you can tell the clinicians, this myeloma is this, and this one is this, and this one is this. They are extremely heterogeneous bunch of diseases. When I say that Lisa Ray is cured, and when I say that somebody died in 8 months, obviously they were at 2 poles and with all shades in between. And that's all genetics. It's not anything outside. It's all genetics of the myeloma plasma cell. I don't know whether
Great. Thank you. Thank you so much, sir. Thank you so much.
You made.
Thank you.
I did understand. I did understand. Thank you. Thank you so much.
Thank you, Dr. Neha. Dr. Fahima.
Hello, sir.
Hi.
It was so nice to hear you, so after so long. It was such a wonderful
Missing the
lecture.
webinars.
I loved hearing you talk. It was so enlightening. And I just have this. I mean, I heard that you have the largest number of patients on Techly. I had two patients. One did extremely well. One I lost to fungal pneumonia. I just wanted your input on, whether we can do anything about the dosing. Are you giving the standard dose? Did you anytime mess with the dose of that?
So I just mentioned to Ramesh that I have burnt my fingers as well. I've not had a death by infection. And FIMA, interestingly, fungal infection is the rarest infection following teclistamab. The commonest infections are bacterial and viral. But having said that, anything can happen to anybody. And maybe that we are using prophylactic antifungal drugs as well. So dose of all these bispecifics and the frequency at which we administer and the duration for which we administer, I think all are overstated. When I say we, I'm talking about the pundits. I don't think they know the right dose, right intervals, and the right duration of therapy. It took 10 to 15 years to know the right dose of TKIs for CML. You agree? Dasatinib from 140 to 100 to 70 to now 50. Same thing happened to other drugs. This is what is going to happen to teclistamab and other bispecifics. And as I told Ramesh, I have already started doing it. So after the first dose and then the second dose, and then I come to the full dose, it is half the standard dose. And then I'm immediately giving it once in 2 weeks. And I'm continuing with the half dose. And once the patient achieves stringent CR or MRD negativity, I'm giving a drug holiday. My patients are doing very bad if I try to do the protocol that has been recommended, mainly from the angle of recurrent non-life-threatening infection, I would say. No one has died in my hands at the moment. And the systemic symptoms of weakness, fatigue, disinterest in the surrounding, some kind of mental haze, whether it is a mild ICANN or what it is, I do not know. My experience with this drug is very small. Jensen is saying that I have largest patient because of they want to keep me happy or what, I do not know. But we are learning. 3 months is not enough. So we need to learn, but you are absolutely right. Be very careful in using these drugs. Maybe half the dose, maybe once in 2 weeks, and maybe we stop when there is no evidence of detectable myeloma in the body and let the patient relapse and use it again. The patients where I've stopped, short period, but they haven't relapsed so far.
Thank you so much, sir. Always a learning with you. Thank you.
Do come to our webinars more often.
Oh, sure, sir. Thank you, sir.
Thank you, Dr. Fahima. So we'll take up some questions from the audience. There's a question from Dr. Saurav Mishra. If you're going for MRD in the frontline setting or a relapse setting, at what time period you do in the frontline setting and at the time of relapse?
If you have achieved stringent CR, after that, probably you can start looking at the MRD. If you're looking at the MRD, you can do PET scan. You do not have NGS available in this country at the moment. Recently, MedGenome contacted me, but the quotation they gave was 43,000 rupees for the test, which majority of my patients, almost all the patients, may not give because I may not be able to act on that information. You must have the top class flow cytometry available next door, which you can trust. So the data available to you should be of that quality that you're going to make clinical impact and change your treatment or modify your treatment accordingly. So having said all those technical issues, yes, documenting a MRD negativity to the 10 days to 4, 10 days to 5, 10 days to 6 is wonderful. It gives you happiness, like you detect your stringent CR one step ahead. Sustained MRD negativity, so you should repeat it at least once or twice more up to 1 year, because that's the definition, that you must have that for 1 year or more. After all that, in clinical practice, what will I do with it? That question always bites me. Which of my patient will have monetary funds availability and mental makeup to modify his treatment based on MRD in myeloma? Most of the time, my answer will be no. It will not happen. So those who have come back from US after their initial treatment, or they've gone there for ASCT, they've got their NGS done there, they've got their flow done there, they've shown that 10^5, 10^-6, etc. have been achieved. When they ask me that I don't want to go back there, I don't want to send the sample there, do it here, I do it. So short answer is of not great clinical value. I don't bother about it for 99% of patients.
Thank you, sir. And another question from Dr. Saurav Mishra. In a relapsed myeloma patient who hasn't undergo frontline transplant, when would you plan transplant in the relapse setting?
Yeah, so indications and the requirements remain the same. I will try to produce as deep remission as possible. So this patient will get 4 or more cycles of treatment of effective drugs. And once the disease is to the rock bottom, this patient should undergo, if I'm confident of getting the stem cell, or I get the stem cell, or I use all the technology to get the stem cell, or of course, he has not undergone transplant, so he doesn't have any stored stem cells. Yes, I will be offering him, if he has not undergone stem cell, he's fit for receiving stem cell now. Yes, all other criteria are fulfilled. So it's just a question of achieving same depth of response as you would have done to a newly diagnosed patient.
Thank you, sir. And is there any opportunity to again give bortezomib re-challenge in the relapse setting?
Bortezomib?
Yes, bortezomib re-challenge.
Re-challenge. Well, almost hardly any patient of mine is on bortezomib maintenance. So I firmly believe that these patients are sensitive to bortezomib. Their bortezomib was long ago. So there are very few patients who have high risk or ultra high risk where I use 2 drugs for maintenance, and then it can be bortezomib for a year, not more than that. Len continues 2 years, 3 years, 4 years. But bortezomib I stop after 1 year. By the time they've got paresthesias, they've got numbness, etc. So in short, all patients receive bortezomib unless I prefer carfilzomib for ultra high risk and high risk patients. So if they relapse, they have that kind of situation, then yes. Or they couldn't tolerate bortezomib upfront, then I don't try it up in relapse also. Otherwise, yeah, majority of the patients will get bortezomib back.
Thank you, sir. And again, another question from Dr. Saurav Mishra. What are the vaccination recommendation relapse myeloma?
All patients of myeloma in my hand get 4 vaccines. If they are not received hepatitis B, and if they don't have protective antibody in their body, hepatitis B, they are all probably in the age group that they should get the flu vaccine every year. They get Shingrix vaccine if they have not had that. And they get pneumococcal vaccine, both the doses, both the types. So, and I start this simultaneously in a newly diagnosed patient. I don't bother about whether the vaccine will work or not. Whatever good it does, if the patient has money, you give it, you can't wait for the treatment. Unless the patient has got a smoldering myeloma or such a benign myeloma that I can wait. Otherwise, this all goes simultaneously. Subsequently, when he is relapsed, the flu vaccine once in a year will continue. Hepatitis vaccine, I don't repeat. Pneumococcal vaccine, I don't repeat. Shingrix, I don't.
Thank you, sir. Another question from Dr. Aishwarya Raj. A patient of isolated CNS relapse. There is no monoclonal M protein, normal FLC ratio. How to proceed?
Well, CNS relapse is CNS relapse, irrespective of what the protein profile is. In fact, that is the bad situation. It may be meningeal relapse or it may be parenchymal relapse. I mentioned in my talk, this is a dismal outcome case. So we use cranial radiation, which is my treatment of choice because it has given me longest survival. We use triple intrathecal twice a week for 6 doses and then change it over to once a month. We give high dose dexamethasone systemically, and I use an IMID for all of them. And the drug of choice for me is pomalidomide because they've had enough of Len already. So pomalidomide, dexamethasone, intrathecal, cranial radiation. I play around these drugs. And then when they relapse again, which happens very fast, you use whatever you want. I'm not very enthusiastic with pursuing their treatment. I don't want them to spend all the money which they rather leave for their family.
Thank you, sir. Another question from Dr. Shushma. What is your take on daratumumab maintenance?
So I have used daratumumab maintenance for my elite class of patients. I believe that a year or 2 of daratumumab maintenance, which is once in a month to start with, then once in 2 months for the second half, and once in 3 months in later period. I stop it by the end of 2 years. Many patients stop it after 1 year. I do this for patients of high risk, ultra high risk myeloma. All other patients where I feel that they require 2 drugs. LEN is my mandatory drug. So this is all addition to the LEN. So those patients where I feel that they require 2 drugs, or there were patients where I wanted to give bortezomib, but I could not give it for some reason. So those patients I give daratumumab. It's not as benign as rituximab, but it is very, very easily tolerable drug. And with subcutaneous route, there is no issue at all. It's expensive drug. That's it. And acyclovir prophylaxis should be continued till the patient is on daratumumab. I've also used it for occasional patient of high-risk smoldering myeloma, whom I have treated with dara. So if I have treated with dara, I may maintain with dara. So overall, these are exceptions rather than rule.
Thank you, sir. A question from Dr. Gurpreet Kaur. Your take on bispecific antibodies versus CAR T-cell therapy in real-world scenario.
In real-world scenario. So if you ask the Western world, they will prefer CAR T first because it is one-time treatment. And you've got bispecifics available on a target different from BCMA. So they can sort of sequence then bispecifics later on as and when the problem happens. And they believe that bispecific is a continuous treatment. In our situation, at the moment, we have access only to bispecific. So we use that. CAR T will come by December. Then this will become a real question. If my patient has little money, which he wants to spend in a spread out fashion, it will be still bispecific. If my patient requires urgent treatment because he got a florid aggressive relapse, it will be bispecific. If my patient can afford a CAR T 40-50 lakhs in one go, and he is ready, his disease allows him to wait for a month or 2 months for the product to be ready, it's not a very aggressive relapse, then yes, CAR T probably should be done. I don't think I'm going to do CAR T in my hands. I'll just hand over the patient to a CAR T center. It's an institutional-based therapy, while bispecific is a clinic-based therapy. Anybody can do it anywhere with little experience.
Thank you, sir. Another question from Dr. Hitha B. She is a patient of 50 years male myeloma, no comorbidities, presented with severe pancytopenia. Bone marrow shows 90% of clonal plasma cells, lambda light chain of 887, kappa of 18, no M band, could not do fish because of finance. After 2 cycles of Cybo-D, the bone marrow again shows 80% clonal plasma cells. Primary non-refractory. How would you go about this?
Yeah. So of late, I have stopped using alkylating agents upfront. I think IMIDs are far superior to alkylating agents. Unless there is a reason, whatever it may be, you should use LEN in place of cyclophosphamide. If there is a problem, you should use thalidomide. If there is a problem, you should use pomalidomide. In short, you should use an IMID. Now, your patient has financial constraint. Your patient has primary refractory disease. So you have all sorts of problems. Dara will be out of question as money is not there. In this patient, I will now use probably, I hope patient can afford carfilzomib, pomalidomide. I'll continue with steroid and see what happens. When you are financially and that happens to all of our patients in 80-90% of the time, you have to again play within those big 5. So you've got 2 tools at the moment. All the IMIDs you've got at your disposal, you've got carfilzomib at your disposal. And carfilzomib generic is not that expensive.
Thank you, sir. Another question from Dr. Jurgutis. What is the dose of carfilzomib in once weekly protocol of KRD? What do you usually use?
In which protocol?
KRD protocol.
KRD protocol.
Dose of carfilzomib once weekly.
56 milligram per meter square once a week. Once a week to 3 weeks, and then 1 week holiday. So per cycle, 3 doses, 56 milligram per meter square, given over 20 minutes intravenously. Day 1, day 8, day 15, and then there is a break, and then the next cycle.
Thank you, sir. Another question from Dr. Raghvendra Rajeshwarkar. Can you please elaborate on the basics of spectrometry?
Spectrometry. So Neha will tell you now. I understand you have spectrometry at Dinanath in Pune. Is that
No, so we do not have a spectrometry at my unit in DY Patil.
okay?
So quite a lot of it is outsourced. We do not have an in-house myeloma diagnosing unit. Even electrophoresis, we need to send it outside. Flows, probably we may plan to start in coming few months, but we do have an in-house IHC unit. So if flow does not help us, we surely go ahead with IHCs. Spectrometry, so unfortunately, we don't. There's a different team which is out of DY Patil who works on that.
So spectrometry is one of the most sensitive way to pick up the M protein in blood and urine. We have spectrometry available at PD Hinduja Hospital in Mumbai in the microbiology department, and they are doing the fungal investigations with the help of this test. You require a software, you require the kits. We neither have the software nor we have the kits. I do not know what will be the cost of this test. And I had heard that it is available in Pune. So I asked Neha, but maybe I'm wrong. We have only theoretical knowledge of spectrometry for myeloma at the moment, but it is the most sensitive tool. And if you look at the population, I mean, that study from Iceland, which I quoted, if you start doing spectrometry, probably every second or third person will have M protein as they age. So no practical experience, it's all theoretical for us.
Thank you, sir. The question from Dr. Hitha B. In a patient who is a young fit patient, can we wait for autologous stem cell transplant till he relapses?
Yeah, so as I mentioned, 90% of Indian patients do not undergo upfront autologous transplant. Money factor, mental block factor in patient or the family, or the consultants didn't advise it. This is I see very commonly. My first choice, as I answered to Arihan, will be to do an upfront autologous transplant in all the patients when it is due, unless patient is unfit or monetary problem or whatever the reason may be, or you are at a very remote place, etc., and patient cannot stay in a third city for a month or two. The problem with the delayed transplant is you may not get the stem cell because you've used so much of IMIDs, etc. The patient may lose his fitness. He was fit when you diagnose him in 2025. And when the late transplant you want to do in 2028, he may not be fit. So these are the two major problems. But yes, if the patient is fit, he has money, now he's mentally ready, then you can do a delayed transplant. That's the indication, I would say, when the patient has relapsed, you've not done the transplant upfront, he's still fit, now he's got the money. Why not? Yes, if you can retry the enough stem cells, sure.
Thank you, sir. Another question he has is that in a case of, this is a question regarding the maintenance in patients who have undergone transplant versus those patients who not undergo transplant, what should be the duration of maintenance with either len or bortezomib?
Those who are not undergoing transplant, your upfront treatment of 3 drugs or 4 drugs must continue for 1 year, not 4 cycles. That's number one. A huge mistake that is made by all around that the moment patient is into CR or stringent CR, after 4 or 6 cycles, patient is straight on maintenance. So that's a mistake for a non-transplanted patient. After 1 year, you get onto the maintenance. If the patient belongs to the group of high risk, ultra high risk, you should use 2 drugs, and that can be len is always there. You should use bortezomib or dara depending upon the finance available. In between can be a place for len plus carfil. Borte, carfil, all that is for 1 year. Dara is for 1 year or 2 year. Len, there are 2 schools of thought. You can give it for 2 to 3 years and call it a day because you're worried about second cancer, or you can continue it till toxicity or the efficacy is lost, patient relapses. Either of the 2 tools are all right. I have many patients who have refused to continue beyond 2 to 3 years because of some side effects, or they believe that it is not necessary. So that's okay. I mean, there are 2 schools of thought.
Thank you, sir. There's a question from Dr. Christopher King. You said that plasmapheresis should be avoidable now in real world scenario. Thus, this also applies to those patients who are coming to you with hyperviscosity, and you give daratumumab and still you will not prefer plasmapheresis when the patient has to go on daratumumab?
Probably not. Hyperviscosity is a very rare phenomenon in multiple myeloma. I must say I don't have a single patient where multiple myeloma patient is presented with hyperviscosity. Those were patients of Waldenstrom invariably. I haven't seen an IgM myeloma in my practice so far. People must have seen. So if you have a hyperviscosity, agreed. But just for light chain of 8,000, 10,000, 16,000, where the nephrologist comes to me that should I start plasmapheresis? I say, if the patient can get DARA, if the patient can get my drugs, 4 drugs induction, I will get you this light chain down to half in no time. So just do aggressive dialysis, and that also not high cutoff. So I have stopped doing high cutoff dialysis, routine dialysis, aggressive in the sense we do it sometimes even every day. And we use simultaneously from day 1. The moment patient is finished with the dialysis, we give DARA, we give bortezomib. I use pomalidomide, and we give 40 mg of dexamethasone. Here I use dexamethasone 40, 40, 40, 40 for 4 days. So we bring down the light chains very rapidly, which probably you may not be doing even with your plasmapheresis. So this, all the comments I mentioned was for the light chain, not for viscosity.
Thank you, sir. Another question from Dr. Bhuvesh Vadnath Gauri. Sir, is there any way to participate in Indian myeloma registry to generate our local data on especially these newer therapies coming up in myeloma?
So please contact Dr. Pankaj Malhotra, who is the torch leader for Indian myeloma group. And we also have, I'm so poor at name, Amit, the one from AFMC Pune.
Dr. Uday Yanamudra?
Uday, right?
Uday. Dr. Uday Yanamudra.
The surname is a bit tongue twister for me. Uday from Pune and Pankaj Malhotra from PGI Chandigarh. They have been very, very active in Indian myeloma group. Please join them. And they have done a lot of data collection, publication, research, yearly conference with international speakers. So I think Indian myeloma scientific group is very, very active, more than any other group. I mean, there are others also. We have Indian Consortium of AML and all that, but myeloma is very active. So these are the 2 guys whom you can contact.
Yes, sir. Another question, sir, from Dr. Ifat. Is the treatment modality and MRD same for biclonal gammopathy as that of monoclonal gammopathy?
Biclonal gammopathy and triclonal gammopathies, I have handful of cases in 40 years. I might have seen not more than 10, 20 cases. I don't know the standard of care for monitoring on this. So we just look at the same parameter. We look at both the M bands disappearing by immunofixation, and we look at the serum free light chain assay. I don't do anything differently for these patients.
Thank you, sir. Another question from Dr. Shyam. In a case of very ultra high risk myeloma, would you directly consider for CAR T cell therapy instead of going for autologous stem cell transplant for newly diagnosed young fit patient?
Absolutely. I will. I mean, I've been criticized for this kind of recommendation, but I think life is very important. You can't play around with the life. So I can get them enrolled in Sloan virtually free of cost for their first line CAR T with the Cilta-cel. I think Cilta-cel is a wonderful CAR T. And Dr. Usmani is my very dear friend. And he has bypassed all the rules and regulations to enroll patients with ultra high risk over there. So if you have a patient of ultra high risk, young fit person, he's going to die. And there's nothing more important than life. I'm not Putin. So if you don't do this, you are killing people.
No, sir.
I think there's only one hope for them, and that is CAR T. It will be standard of care tomorrow, but maybe I'm seeing too much ahead of time. So I say that we just now send a patient of mantle cell lymphoma with TP53 positive to MD Anderson for opinion. And same evening, I got the email that he's being put to CAR T. There's nothing else going to work. So experimental treatment, but he's getting it free. And he's getting a treatment which probably may save him. So all these are cases which don't give you 1 year of life.
True, sir. Another question just come up from Dr. Rajesh Barkar. in terms of antifungal prophylaxis in myeloma, which is the best antifungal prophylaxis would you choose?
Well, prophylaxis has to be oral. It can't be injectable. And oral, there are only azoles. So just choose one of the azole. I find fluconazole useless. I find voriconazole toxic. So my drug of choice is posaconazole, which I've used for AML. So I'm very friendly with it. Bit expensive. So if the patient can't afford, then voriconazole. And if the patient can afford, then it is. I find fluconazole a bit poor drug. Yes, my poorest of the poor patient are on fluconazole, but it is an azole, and it is between these three.
Thank you, sir. A last question from Dr. Deepa Rani. Would you like to assess for hemostatic profile of the patient before starting the therapy in multiple myeloma?
You talk about coagulation profile.
Yes, coagulation profile.
It has not been a standard of care for me. Platelet count we look at. If LFT is deranged, we do the PT-INR. I've not been doing PTT. I'm not doing factor 10. If there is an amyloid, I may do factor 10 and PTT, PT. That's it. I don't think this is standard of care for me. I've not been doing for 90%, 99% of patients. I don't know the reason behind this question. Any?
I don't know.
Would you like to, is she around? No.
She's not around.
No, she's there.
She's there.
Deepa, you are
Dr.
there.
Deepa. Dr. Deepa, you want to ask a question?
She probably not physically present. Okay.
So
There are-
Dr. Rashmi, yeah. Dr. Rashmi Kushwaha, please.
Good afternoon, sir. Thank you for the wonderful talk. Just what Dr. Deepa said, probably because many patients tend to get this acquired von Willebrand disease, and because of the hyperviscosity of the blood, they might have this endothelial injury leading to the activation of the extrinsic pathway. And so probably I think that is the reason she would have asked that question. But even I am not aware how many percentage of patients get this kind of issue in their during their treatment.
Possible. Agreed. Possible.
Dr. Esmi Verma, you have a question? Okay. One question has just come up from, yeah, same thing. Dr. Deepa Rani, again, the same question with Dr. Rashmi Kushwaha has answered about acquired von Willebrand disease. I think she's convinced with that. Fine, so.
I should start.
So,
I have not been looking at it.
okay. So anybody has any other question? Well, so in that scenario, so no other questions from the audience and no more raising signs. So, well, thank you so much, sir, again for the fantastic lecture. A very wonderful lecture, I may say, best lecture. It was a heart-touching lecture, I may say, and a wonderful discussion, sir. Thanks a lot. And I also thank all our audience to participate in this webinar, as well as all our discussants to join today. And thank you, and meet you next week, Saturday, Sunday. And is Dr. Sumit around? Yeah, Mr. Sumit Madan, please.
Yes, sir. So thank you, sir, for delivering an excellent talk, I think, and you have given a holistic and 360-degree view of managing multiple myeloma, and talk was followed by a very, very engaging discussion. I think it was a marathon session that today we had. Thank you so much. On behalf of Zydus, I thank Mumbai Hematology Group for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank our chief guest for the day, Dr. Amit Khurana, all discussants and participants who have joined us for this webinar. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. So thank you so much, everybody, and have a wonderful Sunday.
Thank you, Mr. Sumit, for supporting us.
Thank you, sir.
Thank you so much. Thank you so much, sir.